So I'm pinch hitting for Esther Kim. Esther, although she was a cheerleader, varsity cheerleader in college and did all these backflips, apparently injured her back, so cannot be here. So I am presenting her slides, although I did put a few of my own in here just to kind of share a little bit. So I'm going to talk about iSCAD. So, the first thing I'm going to say is that, there's more than one way to cook an egg. I think everybody in this room, patients and care providers alike, would like to see SCAD just go away. And I think we realize that that's going to take a lot of work. It's going to take a lot of effort. And we're going to all have to kind of figure out what we need to do to understand it better, to get better outcomes to patients, and ultimately to be able to hopefully prevent SCAD. Certainly we need to treat it better. And to the point of the patient who asked about the weight, I think one of the things that's really important is that we continue training junior fellows. And they have been trained by me, by our group, and we review the angiograms once a week. We discuss management in tricky cases, and that has really alleviated our wait time, because as you can imagine, now that the recognition of SCAD is going up, the referrals are coming in, and we want to stay on top of them. So that being said, I think we realize that there is a need for us to work and to solve the problems of a lack of data. And I put this slide together this morning, which is really that there's more than one way to cook an egg. And what I'm talking about here, I found them at 3 in the morning. So the truth is, I didn't even Google heart. I Googled cooking eggs and found these. I think that we have two of the leading groups, obviously, in the world here amongst us who are doing such cutting-edge science. And I think it's really hard sometimes geographically, physically, to sort of get people into appropriate things. And I think the good thing to understand is that we can all continue to do science in our own ways to further the understanding of SCAD. And so I think, we really need to recognize that the way we did research a decade ago may not be the way we do research in the next decade. And I think the term disruptive is probably one of the most overused terms today. But I think one of the things that we've recognized is that we need to be disruptive in the way that we do research, because funding is drying up. And certainly when we're dealing with a condition like SCAD, where we don't have something that's an easily marketable part of our disease, so we're not going to have device or drug companies lining up to support our research. And I think most of us who have really robust experience with SCAD don't have the time to be clinical investigators who are applying for those very, very limited NIH dollars or Heart and Stroke Foundation dollars, although Dr. Saw and her group have been very fortunate in achieving funding. So in the next few minutes, I'm just going to briefly talk about iSCAD. And again, the purpose of this novel project is really to continue to add to the body of clinical research that's been developed thus far. And I think we recognize quality research has to ask a clear question. You need to have solid methods. You need to have accurate data. We don't want garbage in, garbage out. We want great data, curated, and have actionable results. With good data sets, we need to have representative patient populations, sound statistics, and robust numbers. Some of the barriers that exist to advancement of science for rare diseases include small collections of patients, geographic dispersion, and a variety of methods of practice. One of the great things about meetings like this is we get together and we learn from one another about new and different ways of treating patients, so we can share that. But I think there's still a lot of variation in the care and in the ability to properly diagnose SCAD in the community. The expertise has been limited to a few individuals, and as I commented at the beginning, we're really trying to change that. Often these individuals are seated in tertiary academic centers that are not accessible to all patients. Funding has been a major issue because the funding bodies often say, well, this is a rare disease and it's not really generalizable. That has also been an impediment to us sharing information because other organizations that might support that message say this is just such a niche group of patients when they don't recognize that it actually is quite a robust group of patients. I mentioned the small market. Some of the drivers that allow for advancement are really the work that Dr. Saad, Dr. Hayes, Catherine Leon, and others have really developed, which is that patient-physician, patient-patient, physician-physician, and then moving ahead to the administration of hospitals and hospital systems partnerships, because that's really the way to get the message out. Using social media and these patient advocacy groups has really raised awareness, in addition to helping manage the stress and anxiety of patients who are waiting for appointments or who have seen physicians and teams but may not be close geographically to them on a regular basis. And this is also a mechanism for further funding. So the mission of iSCAD, which is the International Spontaneous Coronary Artery Dissection Registry, is to develop and maintain an independent quality data repository to advance pace and breadth of SCAD research with a common goal of improving diagnosis and outcomes while accelerating scientific discovery. And this is not to be exclusive. Patients can participate in a multitude of registries and projects. This is simply one that seems to be a more novel, different way of doing research, and we'll see how it works. The vision would be to collaborate with researchers throughout the world and to continue to upload data live as patients are seen, and to have an adequately powered data set to be able to answer really difficult clinical questions and to work with our colleagues to develop best practices and hopefully eventually guidelines to help with SCAD management. These are some of the folks, the leaders are Dr. Kim, certainly iSCAD, Catherine Leon have been responsible for the funding of iSCAD. Dr. Naderi and I have also worked with the steering committee to help develop, to share ideas and develop the overall protocol. This is the organizing structure. So this really is leveraging the work that clinicians do to gather data from their patients and their referring doctors. We spend a lot of time and effort doing that. So if we can take the data that each clinician has gathered and then send that to a centralized data coordinating center, that prevents redundant effort at additional cost. That does, however, come at the cost of the investigator having to complete detailed paperwork agreements with their institutions with data sharing, data use agreements, and then obviously institutional IRBs. Once the IRB approval is obtained, doctors start to enroll patients. The data is sent to Perfuse, which is the data coordinating center, which is not a recruiting site. It's independent. Data is collected, reviewed, and then ultimately published. That is the goal. And these are some of, this is Dr. Michael Gibson, who leads Perfuse. Many of you may know Dr. Gibson. He founded Perfuse 30 years ago. He has run over 120 clinical trials. He's one of the most highly published and cited scientists that are clinical scientists today. Perfuse has really created a master database that collated all the data from the TIMI 1 through 50 studies. And these mega trials have been looked at to really develop guidelines and approval for drugs like that we're using with the DOACs. Currently, there are 20 sites that have signed on. Thus far, 5 have obtained, 5 are in the middle of enrolling. The rest of the sites are in the process of obtaining IRB approval. That would be even my site, which has taken quite some time just because of data use agreements, etc. The first patient was enrolled in February on the International Day of the Woman, and since that time, 54 patients have been enrolled. Again, 5 sites, 2 sites are in training, 13 sites are still in the midst of recruiting. And Dr. Kim has put together a newsletter to keep the sites sort of aware of what's going on. I don't have access to the iSCAD portal, but there is both a clinician portal as well as a patient portal that has a rolling list of ongoing publications in SCAD. The key elements are that it's an experienced, unbiased, very unique coordinating center that is not recruiting patients. Dr. Gibson and his group have extensive experience with angiographic core lab analysis. They have now looked at hundreds and hundreds of SCAD films, so they have developed expertise in that area as well. There are patient and physician surveys. The sites are really dedicated and committed. It does require commitment on part of the enrolling physicians and teams. Future directions would be a centralized biorepository and imaging core labs for FMD as well. Ultimately, as I said at the beginning, the common goal is better outcomes for patients who are around today, with the goal of hopefully identifying risk factors, susceptible individuals, and preventing SCAD in the future. Thank you.